Professor Ahmed Abogamal. I'm professor of rheumatology in Al-Azhar University, Cairo, working right now as head of rheumatology department, Saudi German Hospital, Dubai. I'm very happy actually to present this webinar with this great experts and professors among different countries with different experience. And coming to my talk, I will present my talk regarding the psoriatic arthritis. I try to highlight, it's a little bit long presentation. I try to cover the domains and targets and the approved medications and how to use it. It's a little bit long, but I try to make it as short as possible with a lot of clinical valuable comments. And finally, in the last 10 minutes of my talk, I will share my screen to my colleague of the talk today, Mrs. Ramlawi. She will present. She's a psoriatic arthritis patient. She is brave enough to give us some advices regarding her experience and journey from the start of her disease to diagnosis, and what she get benefit from our care and what we are need to improve regarding the care of psoriatic arthritis patients. Without further delay, I'll go to moving. This is my disclosure and going to my agenda today. I have agenda, as I said, I will try to summarize the psoriatic arthritis lesions, starting from what is psoriatic arthritis and why it happens and how to assess. Going to the psoriatic arthritis target could be used as a treatment, and how to select the ideal target in your treatment. Psoriatic arthritis, it is usually developed after psoriasis. This is most happening in scenario in almost 80% to 90% of cases, but in 10% we can have psoriatic arthritis before even the appearance of psoriasis. Psoriasis itself affects almost 2 to 3% of the general population, with almost 1/3 of this population could suffer from psoriatic arthritis. And the extent of psoriasis is higher among patients with psoriatic arthritis, especially in some areas like scalp, intergluteal areas, palm, and sole. For sure, psoriatic arthritis is a very heterogeneous disease. We have a lot to say about the presentation of psoriatic arthritis. It may involve the spine, axial spine, and axial joints, looks like spondyloarthropathies and ankylosing spondylitis, and may extend to have a peripheral symmetrical arthritis affecting small joints, looks like rheumatoid arthritis in some cases, and could be oligoarticular, polyarticular asymmetrical arthritis, may affect the enthesitis and dactylitis, so it is very heterogeneous presentation. That's why we like to call it a psoriatic syndrome rather than a disease, because it's involving a lot of tissues with different structures and different, even some pathogenesis could be attributed to some sites and not the others, so it's better to have it as a syndrome. And even this syndrome extend outside the joints and articular symptoms to have some increased prevalence of other metabolic disorders like hypertension, diabetes, and the cardiovascular disease, with increased prevalence also of obesity, Crohn's disease, depression, anemia, malignancy, and even hepatotoxicity and nephrotoxicity from the current medications. Nowadays, we are almost relying about the Casper criteria for diagnosis of psoriatic arthritis or classification patient as psoriatic arthritis based on the Casper, which is published in 2006. Depending on patients have peripheral arthritis, spondylitis, or enthesitis, with at least three points from the coming either skin psoriasis, which should be seen at present or in the history, or at least even if you have positive family history, could be considered as a positive point in the Casper criteria, plus nail lesion, dactylitis, or negative rheumatoid factor, and combinations of osteoproliferation and osteoresorption in conventional X-rays. To speak about the pathogenesis, let us classify the psoriatic arthritis lesion into three main domains: Synovitis, Enthesitis, and Dactylitis, to discuss each one of them in more specific details. Going to Synovitis. Synovitis is the most, I think, is the easier part for assessment in psoriatic arthritis, because all of us as rheumatologists are expert in assessing joints. But the joints in psoriatic arthritis usually have a very unique characteristic in imaging. You have impression, which is not happening in other types of arthritis, which is a combination of bone resorption and the bone formation in the same image. You can find joint space narrowing with marginal erosion with bone proliferation and periostitis, which is very unique for the psoriatic arthritis lesions. And also plus in ultrasound, the synovitis of the psoriatic arthritis is very, very active, showing grade 3 Doppler usual, grade 2 to 3 Doppler activity, which is not matched usually with the grayscale characters. You can say if you have a grade 1 or 2 in synovitis with grayscale, it is always counting higher in Doppler signal, which is not comparable to what's happening in rheumatoid arthritis. But one point to speak about in synovitis, you have always to take care that in Casper criteria may classify some patients with joint pain or joint inflammation even as psoriatic arthritis, which is not actual and have the disease, because there is always a high risk of developing osteophytes in case of osteoarthritis, and also the crystal arthropathy of gout. It's always present, and it is also high. It is high prevalence for crystal arthropathy, gouty arthritis in cases of psoriasis. You should always consider that this joint pain and inflammation is not explained by any other cause of inflammation rather than psoriatic arthritis. Coming to the second domain in our pathological classification, which is enthesitis, which for me actually is challenging. It looks like you are diving in a shallow water. It's easy, but if you are diving in a shallow water, you may meet a shark. This is enthesitis. Enthesitis looks, it's very simple to assess, but actually there's a lot of challenges regarding its clinical pathogenesis and imaging that we can explain in the coming slides. Enthesitis itself, actually, it is the most recent term in the musculoskeletal system. It is almost started to mention enthesitis in the 20th century. And initially it was referring to the point of attachments of ligaments and tendon to the bone. It's first time to report enthesitis, it was in 1971 in a post-mortem species, which analyzing slices from patients with rheumatoid arthritis and ankylosing, and found this inflammation at the attachment point. It is referred to patient with ankylosing spondylitis, and it takes the term of spondyloarthropathy. With better understanding and better orientation for the pathogenesis happening, we start to extend the term of enthesis to be the enthesis organ by adding what's happening in the region of enthesis from the fibrocartilage, the synovium of the bursa, the bone cortex, and the attached ligaments or tendon. So we try to use the enthesis organ as a full definition of what's happening in all the area. Enthesitis itself, it happens almost in 50% of cases with psoriatic arthritis, with dominance usually happening in the lower limb, especially Achilles tendon and the plantar fascia. But we came to the first challenge in enthesitis, which is the clinical assessment. Actually, it is very hard to get a trusted prevalence of enthesitis based on clinical assessment only. And I can explain this in 3 main points. The first one, which is the absence of visible inflammatory signs. The second is extensive involvement of the enthesis, and the third is subclinical enthesopathy. For the first one, the inflammatory signs at the enthesis is usually absence or very few, which comes from the bone side. There is almost complete avascularity of the bone attachment site at the bony cortex. And on the other side, the soft tissue, the tendon or ligaments at the attachments has a very low vessel density and also very low adaptive hyperplasia, which we compare this to the synovitis happening in rheumatoid arthritis. Synovitis is very prevalent, very high adaptive hyperplasia, increased thickness, increased blood flow. So it appears as tender joints and inflammatory signs. It is imminent to see, while it is not happening in the case of enthesial attachments. The second point that enthesitis is difficult to count based on clinical assessment is extensive involvement. If we take only one finger as an example for enthesial attachments, we can count the attachments of the ligaments at the one finger. It's almost exceeding 13 sites of attachments. If we add also the extensor and the flexor tendon attachment, it would be also 3 attachments, and plus the tendon pulleys, which is useful to fix the tendon in place. We can count 5 sites of pulleys, So we have total 21 sites valid as a target of enthesitis in only one finger. So if you take an example for the DIB region, you can find pain and inflammation in only area of about 1 centimeter coming from nail bed inflammation, synovitis, and enthesitis. So it is very difficult to feel it and differentiate it in only hand examination. Coming to the third point for the clinical challenges of the prevalence of enthesitis, which is coming from the imaging data. We have a lot of progressive or growing evidence from imaging data that we have always higher prevalence of enthesitis and assessment by imaging data comparable to the clinical assessment, which happened with all types of trials. I presented only here 3 trials. One of them was Simon et al. In 2016. He present a data of examination of 55 psoriatic patients using CT at MCB joints. And actually, there is significant higher prevalence of enthesitis in patients with psoriasis without any correlations to pain or inflammation at these joints. Coming to the data of MRI, by examination of 52 and 26 patients with psoriasis with negative examination of pain and inflammation on both feet, enthesitis was found in 92% of patients, which means 24 patients out of 26 have a significant inflammation or enthesitis in the lower limb based on MRI examination. Coming to Emilio Flibucocci from Italy in 2012, he examined 600 lower limb sites of enthesis assessed in 60 patients, and he found 60.8% of them have a significant enthesitis based on ultrasound without any clinical signs or complaint as pain before assessing with ultrasound. Why enthesitis happens? Enthesitis actually refer to 2 different loops. We can refer about the downstream loop and upstream loop. In the downstream, at the site of enthesis, we have 2 sets of inactive T cells. One of them is the gamma delta T cell, and the second is the innate T cells. Usually, the process of enthesitis is starting here. For unknown reason, and actually in predisposed patients, could be connected by HLA or not. Patients with psoriasis have a very sensitive fibrocartilage attachment, enthesial attachments to mechanical stress. And some repetition of the mechanical stresses, these attachments start to activate the inner cells to secrete interleukin 17 as the initiator of the signal of inflammation. And under the effect of this cytokine, there start a vasodilatation in the cortical bone with increased chemotaxis and by inflammatory cells and the production of TNF-alpha, following by the process of activation of osteoclast and the starting bone resorption at the enthesial site. Following by the final step with interleukin 22, activation of the second arm of the osteoblast with bone proliferation and spares formation. This is the downstream loop for enthesitis. Going to the upstream, to the main player in psoriasis, which is the dendritic cells. Actually, in dendritic cells, it is secreting 2 sets of inflammatory cytokines, interleukin 12, 23, and both of them act differentially on the inactive T cells to differentiate the cells in 2 different sets, T helper 1 and T helper 17. And both of them secrete sets of inflammatory cytokines ranging from interleukin 2, TNF-alpha to interleukin 17 and 22, which acts again on the cells to activate the loop of inflammation, and finally acts on the enthesial site, causing the spare formations, the erosions, the increased vascularity, angiogenesis, and increased blood flow and inflammation. So as I said before, in the clinical, there's challenges, so we need some help to see the enthesitis actually in the actual prevalence. Enthesis itself, it is a heterogeneous component. We have composed from soft tissue, tendon, bone, insertion line, persa, blood flow, and also we have to test the enthesis in a dynamic assessment to see some entrapment or inflammation of the inflamed tendon. If we rely on X-ray, actually X-ray is very deficient because yes, it's showing the spares very well, but actually it represents a spares of a past inflammation, not active inflammation right now. So the choice usually relying between 2, the MRI and ultrasound, but I am expert in ultrasound, so I present ultrasound as how to use it to diagnose enthesitis and what you can see in enthesial inflammation. Ultrasound can visualize the soft tissue component, which is a tendon or ligament. You can visualize the echogenic pattern of the tendon, the thickness, and if there is any defect inside the tendon. Can visualize the attachment site if there is any irregularities, as we'll show later. Also, Doppler signal inside the enthesial organ itself, PERSA-related, and also can examine the tendon in dynamic assessment. Here, this is a live assessment. You can see the patellar pool starting here. You can see my arrow. This is the tendon, infrapatellar ligament, going to insert into the tibial tuberosity. And this is the cortical part of the insertion. You can visualize the insertion line showing it is clear without any irregularities, and the fibers of the tendon is maintained down to insertion without any thickening or inflammation. And also, this is a part of the PERSA, deep infrapatellar PERSA. It is usually present as 1 or 2 millimeter signal. So this is representing a live examination of the infrapatellar ligament, which is a part of the significant tendon inflamed on both proximal and distal attachment in enthesitis. Looking for here, this is the commonest site of enthesitis, so it's the Achilles tendon. You can visualize here is the insertion line. This is totally destroyed with the combinations of erosions and spurs formation with increased thickness of the tendon, with intrasubstance defect here inside the tendon of Achilles, and some signal of blood flow referring to the bursitis and inflammation. So this is Achilles tendonitis. You can see easily found or diagnose the enthesitis based on ultrasound assessment in Achilles tendon. Coming to the PERSA, PERSA is easily can be seen as distended, as we can showing here. This is a PERSA of the Kager's fat bed with, we can visualize the thickening of the tendon at insertion with the hypoechoic defects inside, and the insertion line showing some mild irregularity in case of enthesitis. In short axis also, we can visualize the PERSA clearly in transverse view with the tendon of Achilles in short axis surrounded by the Kager fat bed. With Doppler signal, we can visualize also the blood flow inside the tendon or around the PERSA, and it's very useful actually to follow the response even for medication in short term and assess the remission in enthesial inflammation, which is a very unique characteristic for ultrasound. You cannot even achieve this using the MRI. Dynamic assessment is very important, and you can see the entrapment of the Kager fat bed deep to the Achilles tendon. This could be a cause of Achilles pain in some situation, and also you can visualize the distension of the superficial Achilles bursitis, which also appears during the dynamic examination. So we can figure out the cause of heel pain in such cases. Another place for inflammation, which is the plantar fasciitis, also a very common site for inflammation. You can visualize the hypoechogenicity of the plantar fascia and increased thickness at the site of insertion, which is defined as an early enthesitis in case of psoriatic arthritis. So we are done with the enthesitis. We know the clinical images that we have is difficult to assess alone based on the clinical assessment. You always need some help from imaging data. And the pathogenesis, we speak about the two different loops, either in the downstream and the upstream pathogenesis, and we get some hints about the imaging using ultrasound. Going down to the second or the third domain in the clinical domains of psoriatic arthritis, which is dactylitis. Dactylitis actually looks like the moon in the sky. It is very easy to see it. It is usually full-blown pictures, fire of inflammation, hotness, redness, tenderness, and very painful. So it is difficult or hardly to be missed. But we have something to say about dactylitis in the clinical scenarios, in the pathogenesis, and we could use imaging, and for what we may ask for imaging in such cases. Dactylitis coming from the Greek words dactylus, which means fusiform swelling of the digit, either toes or fingers, and usually described as a sausage digit due to the fusy or the homogeneous swelling of the digits that obliterate the DIB and VIB region, so you cannot palpate the joint very well. So it's called dactylitis or fusive suture digit due to the homogeneous inflammation and swelling of the digit. Dactylitis is very frequent to happen in psoriatic arthritis, but it is not specific for psoriatic arthritis. It could be happen also in other cases of spondyloarthropathies and Reiter syndrome and reactive arthritis, and even in undifferentiated spondyloarthropathy. And also it happens in another diseases rather than in rheumatological syndrome like TB and infections, sarcoidosis, and it's very frequent to see in gouty arthritis. So dactylitis itself, it is very frequent in psoriatic arthritis, but also could happen to different other causes. The prevalence of, if we go for dactylitis prevalence, we can see a range ranging from 50% to 70% of most cases, but the fixed information here that is always connected to a severe radiological damage. Always high number of dactylitis, all associated with arthritis mutilans as the end stage of inflammation. So dactylitis is always considered as a sign for an aggressive disease in psoriatic arthritis. Dactylitis itself, it is common in the feet rather than in the hands, and usually happening asymmetrical, not on both sides. And if you look for its pattern, it usually involves, in the hand, involves the thumb, index, and the usually happening in the dominant hand, involving the thumb and index. And in feet, in some cohort, it appears to be in the fourth toe, and in other cohort also it is involved, commonly affecting the first and fifth digit in the toe. So it could be ranging from this, its prevalence. Usually appears, as we said, painful and tender, but this is something called cold dactylitis. In some cases of long-standing dactylitis, we have only chronic swelling without a significant tenderness or pain. So why dactylitis happens? If we speak about psoriatic arthritis, there is something called in psoriasis called Koppner phenomenon. Always the lesion in psoriatic patients connected to some friction of the skin or minor trauma affecting the skin. Usually these sites are supposed to have a psoriatic lesion. There's another theory called the deep Koppner phenomena, which is happening at the level of the musculoskeletal tissues and tendon. And actually this theory is supported by the pattern of dactylitis that usually I have in the dominant hand and the most functional fingers, the index and thumb, and also in the feet in the most toes that is eligible for trauma and frictions. So this is supporting that there is something called deep Koppner phenomena that could initiate the dactylitis. For the imaging, actually, dactylitis, as I said, it is like the moon in the sky. It is actually a clinical diagnosis. You don't need imaging to diagnose dactylitis. But for defining what dactylitis involving, for a long time, actually, he was considering dactylitis as a combination of enthesitis, Synovitis, and enthesitis as a combination of the three pathological lesions. And we also was believing that the initiating factor was enthesitis that is spreading the inflammation to synovitis and dactylitis like the joint affection. But if you go to study the recent data coming from imaging studies, especially MRI and ultrasound, we will find that synovitis could be present almost in 17% only of cases with dactylitis. And in in a lot of cases, we didn't found even single enthesitis in the finger. So it is not a fixed component in dactylitis. The only fixed component seen according to this data, it is about inflammation of the tendon polys and the flexor tendon covering. This is always the finding which is seen according to the imaging, ultrasound, and MRI. And this is actually supported also by Dennis McGonigal, who has postulated something called the functional enthesis theory. And this appears that we have this polys from BA to A5, and these polys have an attachment or connection site to the tendon covering here at this angle. And during the tendon movement, there is a friction point between this tendon and the polys, and this could be initiate an area for response for a deep Koppner phenomena that initiate the dactylitis. I will show you more to understand what's happening in the finger during movement. If you look for the left image, which is the black one, there is a small black area that's covering the tendon during movement here. This actually overlies the tendon pulley. This is a normal tendon pulley. You can see the tendon is contracting without any interaction with tendon pulley, but this is a friction site here between the tendon and the pulley itself. And this actually by frequent friction could initiate the inflammatory signal and initiate the inflammation at that site. In the other video here, this is a degenerated and swollen pulley. This is actually a case of trigger finger or stenosing tenosynovitis. You can visualize the tendon is actually invaginated by and compressed, stenosed by the tendon pulley itself during movement of the tendon. Coming to actual case of dactylitis. This is one of my patients. We have psoriasis for a long time, and suddenly he came to my clinic with index finger swollen and tender and red. Actually, when we looked to the ultrasound, he found subcutaneous edema and inflammation of subcutaneous tissue, and looked for the ultrasound picture of the polys here. We found almost 3 black swelling corresponding to the 3 different polys. All of them are swollen and distended. While we look for the joints, there is mild, actually hypoechogenicity and not confirmed even as inflammation. But if you look all the series of the tendon polys all over, the flexor tendon is distended from the palm of the hand to the DIB joint, which means this is a huge inflammation affecting initially the tendon polys and tendon covering. Revision of the same case with Doppler signal. You can look for all Doppler signals here. All of them are present mainly in the subcutaneous tissue and at the site of the poly tendon contact here. You can look for the tendon poly here. Always the Doppler signal is overlying and surrounding the tendon polys, which actually gives a valid point for the functional adhesive theory and the deep Koebner phenomenon as a source of initiating factor for dactylitis. So at this friction site, suppose we have a huge inflammation. This is another case from my clinic showing distension of the tendon polys is a completely normal tendon here and almost completely normal joint. We don't have significant synovitis or inflammation of the joint or the tendon, but the tendon covering surrounding the polys are inflamed and showing a lot of Doppler signals. This is the site for inflammation. And that's why we need imaging. Dactylitis is very clinically seen and very prevalent. You can quantify actually good number in clinical assessment, but we still need some imaging to quantify which part is affected by the inflammation. Coming back to agenda, we finished almost the first part of the presentation regarding the psoriatic arthritis lesions and what's happening to develop this 3 common lesions from synovitis, enthesitis, and dactylitis, with some insights why we could need some imaging help to quantify and detect the actual involvement in inflamed tissues. Coming to the second objective, which is the psoriatic arthritis targets. If we count for almost 20 years from the start of the biologics use till today, was the first molecule approved as a target in psoriatic arthritis is the TNF, starting by Emperor in 2002 to the last year in 2019, where the gozelkumab molecule shows in the last SCR a significant effect through the Discover 1 and 2 trials that have a significant effect in psoriatic arthritis. Now we are counting a 13 molecule could be a valid medications, our targets for the management of psoriatic arthritis. We run for all of them starting, we start always cytokine targeting more than 20 years back by infliximab was the first one. We try to fix the TNF alpha either membrane bound or soluble to stop the intracellular signal and keep the nucleus and nuclear factor kappa beta in a quiescent phase without activation of the inflammatory pathway. And all the data coming from trials of the different types of TNF inhibitors from infliximab, etanercept, adalimumab, and golimumab, all of them showing a significant improvement in ACR20 or joint domain comparison to placebo, which makes them a valid treatment option for cases of psoriatic arthritis. In 2013, we have the first non-TNF drug approved for the management of psoriatic arthritis, which is the ustekinumab molecule. Ustekinumab actually, it is a monoclonal antibody against B40, which is present in two different subsets of cytokines, interleukin 12 and interleukin 23, and both of them acts on two different receptors and leads to differentiation of two different types of T cells. The interleukin 12 directed to T helper 1 with production of TNF alpha, interferon gamma, and interleukin 2, while interleukin 23 acts mainly to the T helper 17 pathway with the interleukin 6 and 17-22 production. Ustekinumab blocks these two different cytokines and actually block the upstream for through blocking the cytokine sets secreted from two different types of activated T cells. Ustekinumab have actually a unique trial that involving the enthesitis as a primary endpoint. If we look for the data coming from psoriatic arthritis domain and functional ability, you found the most bad functional ability of patients with psoriatic arthritis coming from enthesitis and dactylitis, not from arthritis. While if you look for the all registrations or all medication get approval for psoriatic arthritis, you found all of them assessed ACR 20 or 50 or whatever as a joint domain to get approval for the management of psoriatic arthritis. Till now, the only medication used as a primary target or primary endpoint is enthesitis clearance was the ustekinumab, and it actually found a significant effect in comparison to different types of anti-TNF. Going to the the third mechanism approved for the management of psoriatic arthritis, and actually it was interesting to when it is launched because it is the first oral small molecule used to interfere with the immunopathogenesis and inhibit the inflammatory cytokines through oral mechanism, which is apremilast BDE4 inhibitor, which blocks the cyclic AMP pathway towards the inflammatory pathway and promotes the secretion or the pathway for anti-inflammatory cytokine. Apremilast also show a significant response regarding the tender and swelling joint count in comparison to placebo, and this actually an extension trial showing this maintained effect up to almost 5 years of use with apremilast use, and it shows also a significant effect on different domains of the disease from tender joint count, swelling joint count, even the axial, skin, and nail domains. It was very strange from different injections that were already approved in the previous biologics. It was oral and given in titrated dose starting from day 1 to day 6 and after, starting from 10 milligram to 30 milligram twice daily. And the most interesting that is have no risk for TB and no TB screening required before starting the medications. Going to 2016, we have approval for co-stimulatory signal blocking abatacept, which is approved for the management of psoriatic arthritis in 2016. Abatacept works through inhibitions, the co-stimulations by blocking the CD80-86 ligand through the abatacept and transforms the T cells to anergic T cells, which undergo apoptosis. Also, abatacept show a significant up to 40% improvement in the ACR 20 domains after 24 weeks of application in comparison to placebo. Going to 2017, actually, we have a new mechanism of action with good success in psoriatic arthritis, which is interleukin 17 blocking. And we return again to the monoclonal antibodies that target the interleukin 17. We have two molecules going to do this action through secukinumab and exekizumab, and both of them succeed to neutralize the either membrane-bound or soluble interleukin 17. The first comer was the secukinumab, which shows a significant improvement in ACR 20, 50, and 70 in comparison to placebo. And the second comer was exekizumab, also show a significant improvement towards placebo, and actually in head-to-head trials shows superiority even in ACR 50 PASI 100 achievement versus the standard of care, which is adalimumab in this trial. Again, in 2017, we have the first JAK approved for the management of psoriatic arthritis, which is the tofacitinib. Tofacitinib acts in JAK inhibition to prevent the STAT phosphorylation and activation and prevent its release intracellular to inside the nucleus to activate the nucleus factor kappa beta towards the activation of inflammatory pathway. And tofacitinib actually show a significant improvement in comparison to placebo in remission in achieving ACR 20, and even after switching placebo towards the tofacitinib arm, still get profit and try to catch the study group from after 6 months in this trial. Coming to the last approved mechanism of action for psoriatic arthritis, which is the interleukin-23 blocker. Interleukin-23 blocker directed mainly towards the B19 part, which is a part of the interleukin-23 cytokine. Through the guselkumab, actually monoclonal antibody targeting B19 prevents its interaction with T helper 17 signaling pathway and blocks the production of inflammatory cytokines 6, 17, and 22. Discovered 2, which is presented in last ACR, showing a significant improvement, and the study achieved its primary endpoint at week 24 with improvement at ACR 20 response. What's coming in psoriatic arthritis? We have a lot actually. I think by next year we have at least 3 other mechanisms could be approved. It's not a mechanism, other 3 molecules. We have almost interleukin-17 blocker A and F, brodalumab, which is already showing a good response, maybe registered soon. We have the other interleukin-23 of Skyrizi of AbbVie, it's already approved for psoriasis, but it's coming for psoriatic arthritis maybe by Q1 2021. And for JAK inhibitors, actually we have in the last EULAR, we have the select BSCA trial of OPA, the JAK of AbbVie, which showed a very good response in 2 dosing form, 15 and 30 milligram. And you have also, forgetting also the interleukin-1 blocker of Gilead company, it also could be approved for psoriatic arthritis by next year. So maybe by next year, we have almost 16 molecules could be valid as a medication for management of psoriatic arthritis. Coming back again for our agenda, we have finalized 2 of the objective of this presentation. Coming to how to select among all these medications. We have almost 5 mechanisms of actions with 13 molecules approved. Why to select among them, which is based on 2 important factors. The first one, which should be assessed carefully, which is the patient characteristics, starting from patient demographics, patient age, sex, patient plan, need to get pregnant or not, what is the lifestyle of this patient, is traveling or not. And also the second point, which is associated comorbidities. This patient have diabetes, have cardiac disease, what is the, have a risk of infections with TB or not. This is the most important point to be analyzed initially before deciding to go which one of this mechanism of action. The second point, actually it is the disease domain. Which domain of this disease? As we said, we have almost 6 domains affected. Which one is affected? And all this medication have a good data regarding which domain of them. For that, I will always refer to the GRAPPA recommendation, which is the favorite till now recommendation for the management and selection of medication for psoriatic arthritis, because we have psoriatic arthritis has different pathologic lesions, different clinical presentations, and different even immunologic mechanism. So it is logic also to have a different treatment algorithm and protocols for each domain. GRAPPA is based mainly about the 6 domain, as I said: peripheral arthritis, axial disease, enthesitis, dactylitis, skin and nails. And for each one of them, you have to set step or algorithm for starting medications depend on the main domain involved in this in your patients. Starting from peripheral arthritis, if the patient have a polyarthritis, you start with NSAIDs, conventional DMARDs, methotrexate, trazopyrene, leflunomide. All three are working good in polyarticular involvement in psoriatic arthritis. And always we have local injection. If you have few joints inflamed, local injection is very feasible and successful to control the inflammation at joint level. And also you have to consider that there is another causes of joint pain in psoriatic arthritis should be ruled out, as I said initially, especially osteoarthritis and the crystal arthropathy that is commonly present and may mislead your changing the medications or going up with biologics without any sign of activity related to psoriatic arthritis. And also another point, it is the joint count. If you have a very few joint count flared, you can solve it with local injection and no need to go up with another mechanism of action. But finally, if you are failed to control your patients through conventional DMARDs and local injection NSAIDs, you have to go to add biologics. And actually, in the second step, all biologics, all mechanisms still in the same plate. You have interleukin 12-23, interleukin 17, TNF alpha inhibitors, and BDA4, all of them still in the same place for polyarthritis. As I said before, the most favoring factor regarding the patient characteristics and patient profile, if you have a small joint account, 1 or 2 joints, and mild disease for senile age senior patients, you may go for BDA4 inhibitor, could be more safer for these patients. According, if you have patient traveling a lot or have a lot of you need medication to take it every 3 months or something, we may favor interleukin 23-12 blocker. If you may have patients with another domain, skin and polyarthritis, you may favor interleukin 17 blocker. And if you fail one mechanism, it is allowed to switch between different mechanisms until you get remission of your patients. Coming to the second domain, which is the axial disease. For axial disease, actually, we have to start with NSAIDs and physiotherapy to control the pain and inflammation. And if your patient have still showing no response and activity, there is no place actually for conventional DMARD in axial symptoms. Go directly for the step of biologics. And if you fail one mechanism, you have to switch between different mechanisms until you get remission based on the patient response. For enthesitis, actually, we start with NSAIDs and physiotherapy to control the inflammation, and for corticosteroid injection. For corticosteroid injection, you have to differentiate between the site of enthesitis, either it is in weight-bearing joint or not, because there is to be classifying this enthesitis, because in weight-bearing enthesitis like Achilles tendon, it is very dangerous to go for injection without guidance, without trust, so you may injure the tendon and ending by tendon rupture. So local injection, it is very feasible, especially for non-weight-bearing joints like shoulder and elbow. It's very easy to do it and usually recommended. But for lower limb enthesitis, especially for Achilles and tendonitis, it is very careful. It's not feasible to apply due to risk of tendon rupture. And again, if the patient failed, there is also no place in enthesitis to treat with conventional DMARDs. We'll go directly for biologic mechanism, interleukin 23, 17, and TNF alpha or BDA4, and switch between mechanism until we get remission. For dactylitis, we also start with NSAIDs and conventional DMARDs, and again here we are using corticosteroid injection. And for injection, that's why I also highlighted this in the dactylitis domain, that imaging is very useful in this condition. If you're going to inject a dactylitic finger, you need to know first which part is affected. If the joint's affected, you have to go deep to reach the intra-articular part to inject synovitis and also infiltrate the whole tendon and tendon covering and the poly site. If it is just a superficial dactylitis involving the tendon polys and the tendon covering, you don't need to go inside the tendon inside the joint to inject. That's why imaging it could be useful, and also if it is you can do it guided, will be more beneficial and more effective. And again, if dactylitis failed, we have to switch to biologic different mechanism and switch between biologics if you fail one mechanism of action. Finally, we got in time to home messages. As we said, psoriatic arthritis usually present in heterogeneous spectrum of domains, and some of these domains present little or no clinical symptoms. That's why we may need some help from clinical and imaging protocols to quantify these lesions. And from my side, I always recommend ultrasound as the friendliest ideal imaging technique to complete the clinical assessment of psoriatic arthritis. And for PSA, pathological lesions actually express a lot of different interplay between cytokines, and many of them are valid target for the treatment of psoriatic arthritis. And patient comorbidities and patient characteristics, and these also domains involved, it is a vital part to decide which one we'll use to treat your patients. This is actually my last slide. I always invite you all to download the GRAPPA app. It belongs to GRAPPA, showing a lot of assessment scores, a lot of information for your patients, and useful information, a lot of even for slides and data. You can use it for free to present to your fellows. Thank you, and this will end my show now for questions.